Hello, everyone. My name is Grace Pang, and welcome to the Interagency Modeling and Analysis Group pre-meeting webinar series for the conference on integrating machine learning with multiscale modeling. Our speaker for today is Dr. Silvano Day, who is the J. Eric Johnson Distinguished Professor of Engineering at Rensselaer Polytechnic Institute, where he serves as the head of the Department of Mechanical, Aerospace, and Nuclear Engineering, and the director of the Center for Modeling and Simulation and Imaging in Medicine. He received his SCD in Mechanical Engineering from MIT in 2001, and his research interests include the development of novel, robust, and reliable computational technology to solve challenging and high-impact problems in engineering, medicine, and biology. Silvano will be talking about virtual surgery as part of our focus on human safety for this meeting. I'll pass this over to you, Silvano. Thank you.
Thank you so much, Grace. Thank you so much for the kind introduction. So I'm going to be talking about human safety in the context of surgery. The title of my talk, as you can see, is Virtual Surgery. I have no disclosures, and of course, what I'm going to be talking about is my experience with surgeons. I'm a mechanical engineer by training, but over the years, I've worked with many surgeons, and these are some of the collaborating hospitals, academic collaborators, as well as industrial partners. Surgery, as you know, is one of the most complex tasks that human beings are called upon to perform. It requires mastery of very fine motor skills, superb cognitive skills, and the ability to work effectively in a team. Surgery is not only a complex task, but it's also performed in an extremely complex environment of the operating room, full of distractions, interruptions, time pressures, and emergencies. And when you have a complex task being performed in a complex environment, you can be sure of one thing, and that's errors. So the 1999 report by the Institute of Medicine shocked the nation by suggesting that about 98,000 Americans die per year of medical errors. And the cost of that essentially comes to about $29 billion. So this is like a Boeing 747 with 270 passengers going down every day. More recent estimates, unfortunately, put the numbers at much higher, about 440,000 deaths a year, making deaths from preventable causes, medical causes, the third largest cause for death in this country, right after heart disease and cancer. So this is really a quiet crisis in America. So to understand this problem, essentially, we have to dig deeper into what we mean by errors, by human errors, because basically these are errors being performed by well-meaning individuals, not because they want to make an error, but essentially because this is happening. So we have come a long way in our own understanding of what human errors mean. From the rather dark and sinister definition of human error in the early part of the last century, particularly one from Sigmund Freud, or what is known as the Freudian slip. For him, errors are meaningful psychological acts that arise from the attempts to carry out suppressed intentions. Essentially, that connotes that those that are maybe less effective or deficient. To the much more systems approach of defining errors in the current decades, essentially towards the end of the last century that errors essentially arise from both the operator and the environment. So for example, theorists like James Reason has defined errors as a generic terms to encompass all those occasions in which a planned sequence of mental or physical activities fails to achieve its intended outcome, and when those failures cannot be attributed to the intervention of some chance agency. So basically, this can be thought of like a Swiss cheese model. So if you have a stack of Swiss cheese, then when error happens, when somehow all the holes in the stack sort of align with each other, right? So it's not really a commonplace occurrence, but only when certain things align, and it's not really the fault of an operator alone, but also could be systems failures. And theories such as Rasmussen's, for example, provides a conceptual framework in which to understand human errors. And that's based upon basically 3 bins of human behavior. So this is known as the skill rule knowledge, or the SRK framework, that has been proposed by Rasmussen and rather followed in this community. So what it says is that, you know, when we're working on certain tasks which are skill-based, for example, which we know very well how to perform, right? Which are very familiar with the task, errors can happen because of lapse of attention. So for example, a surgeon is suturing, and an experienced surgeon can suture without even thinking about it. It becomes autonomous, right? But still errors can happen because of lapse of attention. Large number of surgeries are essentially rule-based, meaning that um, uh, steps are being followed one after the other, and the operation goes well if the steps are followed correctly. But still, errors can happen because of the wrong rule, misapplication of the correct rule, or non-compliance with certain rules. But the most nebulous of these is the knowledge-based behavior. For example, that happens when the familiarity with the task is not very high and a very high degree of attention is needed to perform the task. For again in surgery, for instance, one is performing laparoscopic cholecystectomy. So that is the gallbladder removal operation. So, and there is chronic inflammation of the anatomy. It's very hard to discern the structures. So essentially when a surgeon goes in there and because of a moment's judgment, one goes and cuts the common bile duct and not the cystic duct, that is an error, for example, which is defined as knowledge-based error. And that requires effortful thinking. And those are some of the things that are very hard to come by in daily life, but those are the ones that sort of lead to disastrous consequences if they actually happen. So bile duct injury is one of those dreaded consequences of laparoscopic cholecystectomy. Add to that the effect of stress in the environment. And there is a well-known theory by Yerkes and Dodson, which sort of states an obvious fact that as the stress in the system goes up, then performance actually increases with slight stress in the system. And there's a sweet spot at which performance peaks, and then the deterioration of performance can be rather catastrophic with further increase in stress. And this sweet spot can actually shift to the left or the right, depending upon many different factors, right? So coming back to the situation of surgeons and why surgical errors happen, we have to look back to the residency model, right? So most of the surgical errors happen in the learning phase of the surgeon, when she rides up the learning curve. And since the time of Sushruta in 600 BC, surgeons have been trained in the see one, do one, teach one paradigm. So the modern residency education system, which was put in place by William Halsted towards the beginning of the last century, has at its core the fundamental principle that surgeons must be trained in the operating room on human patients. So that places a significant risk on the human patients. Also, the chance of a resident encountering rare critical conditions is rather rare before she graduates, completing her quota of about 750 or 800 cases before she graduates. The cost of personalized training is, of course, very high, and there is hardly any way to objectively assess performance and progress of the training. So the residency program, which is flawed to begin with, is further challenged by reduction in the work week, malpractice, increased malpractice liability, and reduced hospital stays, which have all come together to reduce contact hours between the residents and the patients. So basically, in that perspective, so we are talking about human safety and how how that is a critical situation in high performance environments such as surgery. So if you go back and look at what's posted on the wiki about human safety and the background, human safety background, there is a framework that has been put in place which involves 8 levels. So what I'm going to be talking about in this talk and possibly elaborating upon that during the meeting are essentially all these levels. So we are going to be touching upon individual patients and operators. We're going to be touching upon the providers. For the individual patients, we'll actually go down the scales. We're going to be talking about molecular to cellular to tissue and organ levels. And we're going to be talking about the provider, which is the surgeon. Essentially, it turns out that some of the things that we're developing are also applicable to nurses, operating room nurses, right? And then the tools that are used, not only for performing operations, but also measuring performance. So we are introducing smart tools for the measurements. Then, of course, a large part of surgery essentially is about team communication. So technical skills versus non-technical skills. There's a very nice article that has come out in JAMA very recently about the role of non-technical skills in the success of operating rooms, right? So systems as well, right? But the only thing that we are not going to be covering in my discussion essentially is going to be at the population level, and I gather there's going to be another talk on that at that level. But we're also going to be talking about disease and also data and information sharing. So the reason that I'm going to be talking about virtual surgery is because if you look at the SRK framework, the skill rule knowledge framework, residency training based upon simulators or patients can touch upon at most the skill and the rule-based knowledge acquisition and error part. But it's extremely difficult to address the third component, which is the knowledge part of that framework, because it's extremely difficult to recreate that at will. So the virtual environments essentially are a highly realistic environment, immersive environments, whereby human users really interact with the virtual patients using his or her sense of vision as well as touch. Right? So this is a significant paradigm change in how surgeons and other medical professionals achieve competence and reduce errors in the operating room. So in my understanding, virtual surgery has 3 I's. It must be highly immersive. That means there is a seamless connection to the physical world. It must be highly interactive. So in terms of technology, it means 1 second on the wall clock must correspond to a second in the simulation. And the most important I is that it must be highly imaginative. And that's the part that actually makes it separate from reality. So I can actually literally, with the click of a button, introduce complexities that are very hard to come by in the real world, and which can be devastating in the real world. But I can actually increase the complexity, the frequency of those complexities at a level where those can be actually practiced with ease by the surgeons. So in some senses, virtual reality is some kind of a super reality environment where you can generate scenarios and situations on the fly. That's one side of it. The other side of it is essentially that I can also have objective evaluation using metrics which are very fine-grained compared to the real environment. So basically, we have written a paper on that is on the fundamentals of immersive virtuality and the route to surgical expertise based on that. I wanted to point out that virtual surgery essentially is a manifestation of creating highly realistic virtual environments, which has been identified as one of the 14 grand challenges by the National Academy of Engineering. And I wanted to point out that it's a grand challenge because it is not something that the current technology can address immediately. And the reason is because virtual surgery should be something that should recreate the illusion of actually being in a different space, right? If we can't recreate that with a certain degree of realism, and there are papers that actually quantify what I'm talking about, then it is not possible to have positive training transfer. And that's very important for surgeons. And the reason that this is a National Academy of Engineering Grand Challenge is twofold. One is the requirement for interactivity and the requirement for high fidelity. Individually, I don't believe they're grand challenges, but taken together, that makes this a grand challenge. So to simply describe this, interactivity means that we need to have real-time graphics. So think about static frames being presented more than 30 frames a second makes things look moving. So that's the magic behind movies. And then our sense of touch is not that easily fooled. So force information must be updated at 1,000 times or more for our sense of touch to sort of feel things to be robust and realistic. So that really means that we have very little time, about 1,000th of a second to perform the force computations. And when we have to perform the surgical operations and we have to simulate those kinds of operations with high fidelity, we come across the issues of multiphysics, multiphase, and multiscale. So in the actual meeting that is coming up next month, essentially, it's actually coming up later this month, we're going to be delving deep into this issue of how we are going to be able to create environments which are interactive, but also with a high degree of fidelity. And addressing particularly these issues of coupling different scales, where also you're going to have multiple physics and multiple phases of matter, solids, liquids, and gases involved, right? So we are talking about the physics as well as the scales and how that lets us do computations in real time and and how that can be integrated in large-scale simulations, in team dynamics, for example, in teams of surgeons and nurses working together, and so on and so forth. So with that, I'm going to conclude today's webinar and hope to see you all there in the actual meeting.